Welcome to the ASGE Video Tips Series. I'm Dr. Chris Thompson from Brigham Women's Hospital, and I'm here with one of our bariatric endoscopy fellows, Dr. Andrew Storm. And he's going to tell us about a patient that had a gastric bypass and is now gaining weight.
Thank you so much for having me. This is the most common complaint we see in bariatric endoscopy clinic. And to tell you about our typical case here, she's a 37-year-old female. She had a Roux-en-Y gastric bypass 8 years ago. She also had type 2 diabetes that required insulin therapy. At the time prior to her bypass, she weighed 350 pounds and had a BMI of 56. Her nadir weight was 180 and with a BMI of 29. She regained 80 pounds to a BMI of 42 over the past year or two. She would prefer to avoid surgery, and so she's come to us to see what we could offer from an endoscopic perspective. So we'll take you through how we think about these patients in clinic, and then also show you her upper endoscopy in the evaluation of her weight regain.
For patients presenting to clinic with weight regain after Roux-en-Y gastric bypass, one initial step in their evaluation is to examine their post-surgical anatomy shown in this illustration. Post-surgical complications which may lead to weight regain after Roux-en-Y gastric bypass include gastrogastric fistula, as diagrammed here, as well as dilated gastrojejunal anastomosis, diagrammed here. Careful endoscopic evaluation of our previously described patient involves first evaluating the gastric pouch for any evidence of fistula, also for pouch dilation, and finally for measurement of the aperture of the gastrojejunal anastomosis. The pouch length can be measured with the scope from the gastroesophageal junction to the edge of the anastomosis. The area is then carefully examined for evidence of ulcerations or disrupted sutures or staple material. The gastroscope is then retroflexed to evaluate for any evidence of more proximal fistula or post-surgical pathology. The blind limb of jejunum may be measured and examined, and note that a long, blind limb may develop ischemia at the tip, leading to abdominal pain. This is also known as the candy cane Roux syndrome, which generally requires surgical blind limb resection. We also routinely examine the Roux limb as far as the gastroscope will allow. Attention may then be turned to measuring the gastrojejunal aperture, which may be estimated in comparison to the distal end of the scope, or more precisely measured with a 3 cm snare. The snare is opened until it touches the opposite walls of the anastomosis, is then externalized and measured. Our patient's stoma is approximately 28 to 30 millimeters based on this measurement technique, and she will be scheduled for an outlet reduction procedure with endoscopic suturing.
There's no clear consensus on a definition for weight regain. However, 15% weight gain from nadir has been suggested. This will happen in up to 30% of patients following gastric bypass within 2 years, and some sources suggest in up to 64% of patients within 4 years. This certainly may be associated with the return of comorbid illness, including hypertension, diabetes, sleep apnea, and arthritis. And revisional surgery is highly morbid, with a reported morbidity rate of up to 50%, and in some series a mortality rate of 1 to 5%. As such, a minimally invasive endoscopic approach is desirable. Weight regain may be due to several different causes and is likely multifactorial. The medical conditions that can impact weight gain include anemia, hypothyroidism, and certainly a maladaptive eating behavior, conversion to soft calories, and what has been referred to as grazing behavior with continual snacking can lead to weight regain. Additionally, complications related to surgical anatomy can contribute, including formation of gastrogastric fistula or a dilated anastomosis or gastric pouch. This figure illustrates the association between gastrojejunal stomal diameter and weight regain. Patients start regaining weight at an average stomal diameter of 15 millimeters, and then the association is linear with patients regaining more weight the larger the stomal diameter. The basic clinical evaluation includes a CBC with iron studies, TSH, and nutritional consultation. It's also advisable to consult with a lifestyle coach or exercise physiologist. We also review prior records, including complications from surgery, surgical anatomy, as well as comorbid illness. To reiterate important parts of the endoscopic evaluation, of course, we need to make a careful examination of the pouch itself. We like to retroflex in the pouch to rule out any proximal gastric fistula. We measure pouch length, and we also estimate the gastrointestinal anastomotic diameter, and anything greater than 15 millimeters we consider to be dilated, and this will potentially impact our treatment options.
So now that our patient's undergone a normal clinic evaluation, all of her labs were normal, and then an endoscopic evaluation which showed the dilated gastrojejunal anastomosis, what do we think about in terms of what we should do next for her?
Well, we certainly still want to get her in with a good bariatric nutritionist. It's very important. We'll do some nutritional counseling, make sure she's eating certain things. We don't want these patients eating soft calories or what they call sliders, and we don't want them grazing, having lots of snacks. We want them to have discrete meals at certain times of the day, and we want them to be eating solid calories, things they need to chew that don't slide down easily and get very quickly absorbed. So we cover some of the basics, and then we also get them in to see a good bariatric nutritionist. And of course, there is an anatomic abnormality here that we can address endoscopically. So we do perform transoral outlet reductions in these patients with very good success, and that's going to be the topic of a different tip. So that's what we would plan for next, to start to get them kind of lined up for that procedure. Now, that procedure is very effective, but it has to be part of a multidisciplinary approach, because it's really just a tool to help them lose weight, and if they don't change their life kind of along with this, they're not going to have good durable results.
Great, thank you.
Thank you.